Now,
Good afternoon, doctors. On behalf of Heathrow Healthcare, I, Dr. Prashant Khandeparkar, welcome you to this webinar on troubleshooting PCOS. Doctors, as you know, at Heathrow, we market products in multiple therapy areas like in gynecology, dermatology, orthopedics, pulmonology, etc. With a very strong R&D support, we have developed many unique formulations, keeping patient benefit in mind. Our endeavor is to develop products, formulations, and combinations which will improve patient compliance and ultimately a better clinical outcome. We have developed NSAID patches, rivastigmine patches for patient compliance. At Friends Are Division Doctors, gynecology, obstetrics, and IVF is an important therapy segment for us. We market products for vaginal health like Feminora, Pellitra, etc. We have formulated and introduced a vaginal film containing lactic acid. In oral formulations, besides Didropal and other products, we market Mylotin. Mylotin is a unique nutraceutical for PCOS management. Mylotin contains myoinositol, dichloroinositol in a ratio of 40:1, along with chromium picolinate and melatonin, and folic acid and vitamin D. To speak more about PCOS and management with nutraceuticals, we have today with us Dr. Pankaj Shah. Welcome, Dr. Pankaj Shah. Dr.
yes,
Pankaj Shah is MBBS MD from Ahmedabad, BJ Medical Ahmedabad. Sir is director and consultant at Pooja Hospital, Mumbai since last 33 years. A specialist in high-risk obstetrics, infertility and laparoscopy. And Dr. Pankaj Shah is ex-consultant at Chowksy Municipal Hospital, Malad. Welcome, Dr. Pankaj Shah, once again, and over to you for further deliberations.
hello, good afternoon, everyone. Today we will discuss the troubleshooting PCOS. Nowadays, PCOS is very common in adolescents and adults. It is a complex disease. PCOS in the female having a 50 to 70% have a hirsutism. 50% women are diagnosed in the adolescence phase, when 5 to 10% women in reproductive age of the PCOS. 30 to 75% patients have obese or overweight, and 50 to 70% have insulin resistance. Every 5 women in India suffer from the PCOS. Cystic ovarian syndromes or disease. This is one of the most prevalent endocrine condition affecting the reproductive age, also known as anovulations or Steele-Leventhal syndrome, which was previously labeled as a Steele-Leventhal syndrome. The condition where at least one ovary have a ovarian volume greater than 10 ml, and at least one ovary have estimated 10 small cyst or follicles with a diameter ranging from 2 to 9 millimeter. It is usually diagnosed when complications develop that significantly reduce the patient's quality of life. Usually have a hair loss, alopecia, acne, obesity, anovulations, amenorrhea, infertility-related problems. Steele-Leventhal disease was classically described in 1935 by Steele and Leventhal jointly. It is a combination of hyperandrogenism, menstrual irregularity in the way of anovulations, amenorrhea, or oligomenorrhea. And on sonography findings, it is a polycystic ovary. Usually affects the reproductive groups, irregular menstrual cycle, hirsutism, infertility, and pregnancy complications. Metabolic features showing insulin resistance, diabetes, mellitus, and serious complications, changing in the lipid profiles, psychological effects by the way, anxiety, depression, mood swings, reduce the quality of life, and loss of the self-esteem. The neonatal four key contributors alteration in the PCOS, hyperandrogenemia, and persistent low-grade inflammations. Usually, these are all with environmental toxins, genital and it features subfertility and metabolic risk and metabolic disorders. The criteria antibiotic changes with the patterns. In 1990, it was NIH criteria, which was hyperandrogenism is a clinical or biochemical signs of hyperandrogenism. Same ovulation, ovulations, and they labeled after exposing the dose. When both the things are there, in 2003, it is a Rotterdam as revised and to polycystic ovarian morphology. After the excluding the criteria of endocrinopathy, any of the two things, a clinical or biochemical sign of hyperandrogenism or polycystic ovarian morphology. Of the three, if two are there, it's labeled as a PCOS. Then access, they also put the same or polycystic ovarian morphology.
Prashant sir, are you reaching him? Prashant sir?
Yeah, I was trying to call you. The doctor is logged out.
Why logged out?
I don't know. But see, first of all, his presentation, I mean, I couldn't hear him properly.
Yeah, I know. His
Want to slides, which I was calling you, whether we should tell doctor. In between, he's logged out now. We'll tell Priya.
But why did he log out? Because
I'll call her up and I'll tell her.
Net was not good, or
I don't know whether he went off because of poor internet or what. I don't know.
okay, I'm just
I'll call Priya.
closing the recording. Shall I stop the live streaming? What do I do?
No. You're talking just you're calling her, then I'll not call, because
Sir,
I said you call Priya so that
Priya is there.
we get
online
guidance
here.
what is to be done now.
Priya, can you come online, please?
Yeah.
Priya? Stopping the live streaming, sir. Prashant sir? Hello?
Yeah.
I'm
Yes.
stopping the live streaming. Hello.
Hello.
Shall I stop the recording in the live streaming?
Hello. I can hear you, Vijay.
Yeah. Can I stop the recording in the live streaming? I think doctor has joined again.
Okay. Okay. Yes.
I think you have to conduct it from the beginning again.
I think he'll start now. Let's see. Yeah, sharing.
Hello. Hello.
Yes, doctor.
Hello.
Yes, doctor. I think
Yeah,
you started.
you can hear me?
Yeah.
Yeah.
Start it from the beginning, doctor.
From
That would be
beginning, yeah?
proper, so that we can cut off
Yeah.
the whole beginning portion.
No problems.
Okay, doctor.
Yeah.
All the very best.
Today we will discuss the troubleshooting of the PCOS. PCOS is a complex disease having a 50 to 70% have a hirsutism, 50% women are diagnosed, and 5 to 10% women of reproductive age have a PCOS. 30 to 75% are obese or overweight women, and 50 to 70% have a insulin resistance. Every 1 in the 5 women in India suffer from the PCOS. Polycystic ovarian syndrome, PCOS, one of the most prevalent endocrine disease affecting the reproductive age, also known as a hyperandrogenic anovulations or Stine-Leventhal syndrome. A condition where at least one ovary have a ovarian volume greater than 10 ml and at least one ovary have estimated 10 small follicles with diameter ranging from 2 to 9 millimeter development. It is usually only diagnosed when complications develops that significantly reduce the patient's quality of life, hair loss, alopecia, acne, infertility-related problems, or anovulations, oligoamenorrhea. Stine-Leventhal disease was classically described by the Stine and Leventhal in 1935, having a hyperandrogenism, menstrual irregularity, and polycystic ovaries. It is usually found in the reproductive age group with symptoms irregular menstrual cycles, hirsutism, infertility, and pregnancy complications. Metabolically, features like insulin resistance, diabetes mellitus, and cardiovascular complications. Some have psychological symptoms like anxiety, depression, mood swings, reduce the quality of life, and poor self-esteem. It is a disease, according to the Barr et al., the 4 key factors contribute to the pathophysiology alterations in PCOS. Changes are hyperconsumption of the carbohydrate, hyperinsulinemia, hyperandrogenemia, and persistent low-grade inflammations, which are due to affected by the environmental toxins, genetical disposition, which hormonal imbalance, hyperandrogenism, and insulin resistance. They all contribute by hormonally changing in the FSH-LH ratio, decrease the FSH production due to increase the LH ratio. Hyperandrogenism is a increase the serum testosterone level and decrease in the serum hormone binding globulins, insulin resistance, increase in the serum insulin levels, and decrease in the glucose tolerance. All contributes to the PCOS, and it come out as a symptoms like a clinical feature of hirsutism, acne, reproductive features like oligo or anovulations, irregular menstrual cycle, subfertility, and metabolically with the increased metabolic disorders. The criteria diagnosed at different levels with the 1990 NIH criteria shows hyperandrogenism with a clinical or biochemical signs of hyperandrogenism along with that chronic anovulations with exclusion of the other endocrinopathy for the cause of the hyperandrogenism and chronic anovulations. If other are excluded, then it was diagnosed as a PCOS. In revised Rotterdam has changed in the 2003 has added the one of the criteria of the sonographically diagnosed polycystic ovarian morphology, and he has added the things one more and then say out of these three criteria, any two criteria are there, whether hyperandrogenism, anovulation, or polycystic ovarian morphology, then it is diagnosed as a polycystic ovarian syndrome. Then in the PCOS criteria, they change the with the showing the clinical or biochemical signs of hyperandrogenism must and other two criteria, oligoanovulations or morphologically, if you see sonography finding of the PCOS, then is labeled as a PCOS. Clinical evidence of the hyperandrogenism include hirsutism, acne, alopecia, all of which anovulations will relate to the effect of the androgens on the pilosebaceous units. Hirsutism is a growth of the terminal thick coarse hairs on the face and body in the male patterns. Hirsutism is one of the most obvious clinical indicators of the androgen excess and is important features of the PCOS. It is a sign all are clinical hyperandrogenism. Acne, prevalence of the acne is 12 to 14% among the white women with the PCOS, higher in the Asian Indians and women of the Mediterranean descent, approximately 25%. Alopecia, androgenic alopecia describe the scalp hair loss in the woman, also can result from the hyperandrogenism and is recognized but uncommon feature of the these are all features of the PCOS. Less than 5% of the women with PCOS complain of the hair loss. Typically, the hair loss is limited to the crown and does not involve the frontal hairline. Normal ovulatory or menstrual dysfunctions with the normal intermenstrual interval ranges between 21 to 35 days. If this affects this cycle affects of the more than 35 days or less than 21 days, that is a indicative of ovulatory dysfunctions. Majority of women with the PCOS, approximately 60 to 80%, exhibit the menstrual dysfunctions. And most common abnormalities are oligomenorrhea or amenorrhea. PCOS takes its name from the enlarged ovary, so commonly observed in the woman with the polycystic ovary chronic ovulations and ovulations. Polycystic ovary typically exhibit increase the size and stromal volume and increase the number of the small follicles. Rotterdam criteria consider only total number of the follicle requiring 12 or more, measuring 2 to 9 millimeter in diameter, means of the both the ovaries. Polycystic ovaries, prevalence of the polycystic ovary is quite high among the women with androgen excess. However, from 8 to 25% of the normal women and even 14% of women using a oral contraceptive, also with the criteria of ultrasonography criteria for polycystic ovaries. Moreover, polycystic ovary are commonly observed during the normal pubertal development and even in the woman with the hypothalamic amenorrhea or hyperprolactinemia. In 2003, Rotterdam diagnostic criteria expanded the populations of women that might be assigned diagnosis of PCO by approximately 50% compared to the criteria earlier recommended by the NHCHD2 entirely to the inclusion of the polycystic ovary. Normal gonadotropin secretions increase the serum concentrations with the normal FSH level and increase the LH FSH ratio are typical in the hormonal secretions, but more so in lean than in the obese woman with the PCOS. In the past, increased LH FSH ratio, example, raised more than 2 GM1 has been regarded as a marker of the PCOS, but the ratio varies with the assays used to measure the gonadotropin secretions concentrations. With the change of assay, this ratio also change. Consequently, gonadotropin level or ratios are not reliable diagnostic criteria. They neither make or not exclude the diagnosis. Insulin resistance, overall prevalence of the insulin resistance among the women with the PCOS is between 50 to 75% and greater in the obese than the lean woman with the PCOS. Most common with the PCOS and insulin resistance are young and have ample pancreatic beta cells reserve. Consequently, they are able to generate compensatory hyperinsulinemia, allowing them to maintain normal glucose homeostasis at least in the fasting states. Dyslipidemia, the most common metabolic abnormality observed in the woman with the PCOS. Nearly 70% have at least one borderline or elevated lipid levels. Insulin resistance and hyperinsulinemia are associated with the decreased high density lipoprotein, that is called HDL, cholesterol, and elevated triglyceride levels. Some have also observed elevated low density lipoprotein concentration also. Evaluation of the woman with the suspected ovarian polycystic ovary syndrome should be include serum thyroid stimulating hormones, serum prolactins, 2-hour oral glucose tolerance test, fasting lipid profile, endometrial sampling in a woman with the history of the potential long-term exposure to the unopposed estrogens, usually find in the endometrial sampling as a proliferative phase or hyperplasia. Serum testosterone in a woman with the moderate or severe hyperhirsutism. Morning follicular phase serum 17-hydroxyprogesterone in a woman with the pre or perimenarchal onset of the hirsutism and family history of the congenital adrenal hyperplasia or high risk ethnicity. Overnight dexamethasone suppression test in women with the sign and symptoms of the hypercorticolism. Infertility affects the 40% of the women with the PCOS. PCOS is the most common cause of the annual infertility. Approximately 90 to 95% of annual women presenting to the infertility clinic have a PCOS. In addition, spontaneous abortions occurs more frequently in PCOS with incidence ranging from the 42 to 73%. Inherent ovarian disorder. Studies shows reduce the rate of conception despite therapy with the clomipene. Investigation, serum testosterone level, serum dihydroepistrone sulfate level, 17-oxyprogesterone levels, serum TSH levels, serum prolactin levels, serum FSH and LH levels, total estrogen levels, serum hormonal binding globulin levels, lipid profile, AMH levels, transvaginal sonography with the showing the necklace pattern of the follicular arrangement in characteristic ways, and 2 hours OGTT. Goal of the treatment. Goal is to regularize the cycle, improving the insulin sensitivity, reduction of the weight, improve the fertility and conception rate, and decrease the androgenous symptoms. Management of the PCOS. PCOS is a condition in the that span of the live woman fetal programming may present in the beginning with a syndrome characteristic who can have a series of medical consequences in the adulthood and old age. Menstrual and fertility problems evolve into metabolic complications as age advances, with the early diagnosis being crucial if the aforementioned sometimes fetal complications are to be avoided. A precise diagnosis is very important, especially at the extreme end of the reproductive lifespan. Lifestyle therapy tends to be first step in the PCOS management, especially when excess body weight is associated. Pharmacotherapy is frequently used to manage the most predominant manifestations in each age group, such as irregular menses, hirsutism in adolescents, acne in adolescents, fertility problems in the adulthood, and metabolic problems and risk of cancer in the old age. Lifestyle improving the outcome. Explain therapy, fertility, reproductive, and metabolic. Healthy lifestyles, healthy eating, regular physical activity are very important for excess weight gain. Prevention is important for all the women with the PCOS regardless of the weight. Overweight or obese women aims to 5 to 10% weight loss if they plans. That will give a good improvement in their clinical symptoms within the next 6 months. That is not specific, but more of the fiber food, and which cut down the 30% of the calorie level deficiency. Exercise is prevention of the weight gain is very important, and moderate intensity. They at least have a 150 minutes exercise, more than 150 minutes exercise in a week, or vigorous exercise of more than 75 minutes per week. For weight loss, they have a moderate intensity exercise having more than 250 minutes per week, or vigorous exercise of the 150 more than 150 minutes a week. Behavior strategy includes goal setting, self-monitoring, slower eating habits, low androgen contraceptive pills that contains drospirenone or progesterone only pills known as a mini pills, inositol supplement, that is myoinositol and dechiroinositol, or combination of the both, which can help in PCOS symptoms such as hirsutism, acne, and ovulations. Difficulty in considering ovulations. Another pharmacological factor substance is metformin, lipid lowering agents for a woman with lipid abnormalities. Lean PCOS only for the correction of the PCOS is very important to infertility, correction of the PCOS, and correction of the ovulations. Obese PCOS with the correction of the PCOS along with the weight loss is very important, and having the insulin resistance in the PCOS, correction of the PCOS, and sensitization of the insulin is important. Hormonal imbalance, PCOS, correction of PCOS, and regularization hormonal cycle is also important. None of the physical formulation have a complete things for the all the thing at a one time. No have a complete formulas which gives a complete therapy. The minocytols group active ingredients is minocytol with dichlorominocytol in the ratio of 14:1, which regularizes the menses, improves the egg quality, and restores the ovulations. Chromium picolinate, which improves the insulin sensitizations. Melatonin will improve the oocyte quality. Vitamin D3 also improves the ovulations, and folic acid will improve the oocyte qualities. With all these combinations is one of the near ideal therapy. Minoxidil and dichloroacetal the PCOS studies have fivefold decrease in the MI levels of the ovary. Follicular development is impaired owing to the reduced MI levels in the ovary. Combined dose of MI and DCI is administered, which is found to be extremely beneficial in the treatment of the PCOS. Minoxidil has a substantial role in ovulations, while dichloroinositol have a role in insulin resistance, improving the insulin sensitivity. So there is a medical rationale to administer them together. Thereby, combined administration of minoxidil and dichlorominoxidil in a physiological plasma ratio of 14:1 is considered as a first-line approach in the PCOS patients. Recommended dose of the minoxidil dose is 2 grams twice a day. Management of the minoxidil with the PCOS using minoxidil and folic acid. Benefit of the MI-DCI ratio in 40/1, which our two stereoisomers of inositol insulin sensitizers. In the human ovary, minoxidil is the second messenger of the follicular stimulating hormones, and it mediates the FSH signaling, which increases the FSH level and helps in the ovulations. DCI is a aromatase inhibitor, and thus MI-DCI ratio allows the treatment of the polycystic ovarian syndromes. MI-DCI ratio were able to improve the regularity of the menstrual cycle, acne score, endocrine and metabolic parameters, and insulin resistance. Chromium is combined with the picolinate in order to increase the gut absorptions. When it gives in PCOS, it reduces the hyperinsulinemia and hyperandrogenism. It acts as enhancing the insulin signaling, improves the insulin sensitivity, and facilitates the fat loss. It is better tolerated than metformin. Combined action of both the inositol and chromium picolinate on the insulin regulation will help to treat the underlying cause of the PCOS. A study of the metformin versus the chromium picolinate in the clomiphene citrate resistant patients of the PCOS, and that conclusively chromium picolinate was better tolerated compared to the metformin. They have less side effects of GI of the metformin. Of the metformin versus chromium picolinate in the management of polycystic ovarian syndrome, which is trials are done, second trial, which is have also concluded the chromium picolinate was better tolerated than metformin due to lower side effects. Is melatonin needed? Yes. Concentration of melatonin in pre-ovulated follicular fluid is lower in a woman with the PCOS. Melatonin supports the nuclear maturations of the oocyte in vitro. Melatonin administered may be helpful in vitro fertilization strategy and improve the clinical outcome in PCOS. Therefore, melatonin may provide improvement of the oocyte quality and increase the pregnancy rate. Melatonin is a sleeping-inducing hormone. It lowers the stress. It is used in so many places in the reduce the stress also. role of the melatonin is found in the PCOS, polycystic ovarian syndrome, one of the reviews, and the results says based on that metabolic dysfunction is a major finding contributing to the initiation of the PCOS, and melatonin can hinder this process via its improving effect on the metabolic functions. Melatonin effective to reduce the microscopic symptoms of polycystic ovarian syndrome related to the infertility, and when they cytologically also it is found improving the results. Melatonin administered increase the expression level of the MT1 receptors, GDF9 and BNP15 in the PCOS at protein and mRNA levels, and was determined that melatonin administration reduced the microscopic symptoms of the PCOS, and melatonin was found effective via MT1 receptors in pathogenesis of the PCOS. It suppresses the transport pathway of GCF9 to granulosa cells in antral follicles. Melatonin in the clinical management of the polycystic ovarian syndromes is very important and helps polycystic syndrome as one of the most prevalent endocrine disorders affecting the woman of the reproductive age. PCOS is characterized by oligoannulations or annulations and excess androgens. Recently, pineal hormones melatonin earned serious attention for clinical use of management of the PCOS and infertility. Melatonin treatment lead to improvement in the ovarian function, oocyte quality, metabolic and hormonal profiles in PCOS. Accumulating studies provide prelusive evidence in favor of conjecture that melatonin, due to its broad spectrum antioxidant property, may play a very critical role in the care and cure of the syndromes. Then folic acid manages infertility rooted in the ovulation problems for a woman and with or without PCOS. Vitamin D3 also play key role in helping some women seeking treatment of polycystic ovarian syndrome related infertility to get pregnant. Thank you. Basically, these combinations have very good results in practice, last from 16 to 18 years. The molecule introduced, it was very well helpful, especially those who are previously we used to do the clomiphene citrates. And when then resistance, the things doesn't have, we have to go to the gonadotropins. But after introduction of the minoxidil and dichloroacetal, it has really improved the oral management of the infertility in the PCOS patients.
Correct. And other ingredients like melatonin or folic acid also contributes.
Yeah, both are contributes. Chromium
Yeah.
picolinate also contributes very well.
Yeah. Sir, when you use chromium picolinate, it would be ideal to, in the blood sugar management, which is very common with obese type of PCOS,
Yes.
I suppose.
Yeah.
Now, this particular type of combination, would you prefer it in lean type of PCOS or obese type of PCOS?
This combination will help in both the PCOS.
Both the
But
PCOS.
it helps very much in the obese PCOS. And
Okay.
basically, more of the PCOS is commonly found in the obese patients. We find
Okay.
the 5 to 10% in the lean patient also. But this combination is more in the obese patients when they come for the
Okay.
infertility and adolescent patients with the acne and all the things.
Okay.
So this combination is good for both the type of the patients, but more in
Okay.
the obese patients.
Okay. And I suppose obese will be more common in elderly type of patients.
Yes.
And even there
Now,
are
with the adolescent patient also,
yeah,
so
okay.
many young girls come with the amenorrhea or delayed amenorrhea, oligoamenorrhea. In that also, irrespective of fertility, if we give it very good results, and because their parents they doesn't want to give hormones, cyclical hormones.
Absolutely, absolutely,
They want
yes,
as a anti-androgen, we want drospirenol or anything pills, but they don't want. They think
correct,
it is a cyclical pills.
absolute.
So
And
in that case, their adoption, their acceptance is more important. Of the parents also.
a non-hormonal is anytime preferred.
Yes.
Yes. And the PCS we have described is of reproductive type, metabolic type, and psychological. In which of the symptoms would be properly handled by these type of combinations?
Basically, those who have anxiety, and
Okay.
especially infertility patients, they have a background because due to the amenorrhea or oligomenorrhea, some in the family or society, everyone is behind about their menstrual irregularity when they want the conceptions.
Correct.
So they are psychologically always upsets. In-laws, all the things
Absolutely.
they have
Yeah.
upsets, and then this combination melatonin, all this helpful with them.
Correct. Correct. And generally, after how long do you see the clinical results?
Within the 6 months,
Which is,
they have good results.
generally, do you
I
prescribe for
usually
how
give
long?
I usually give till she conceives. With the PCOS
Okay.
patients, sometimes
So,
patient comes with the PCOS. I give 3 months first before starting anything. Start for 3 months. Tell them to go to lifestyle changes along with these combinations. Do for 3 months and then come back with me with the some at least 5 to 10% of the weight loss.
absolutely correct.
So
Correct. That's
they are
another
from
important.
they don't feel from day one we have cycle started, yeah, a follicular study started, treatment started. We
Correct.
give them just consider you try first with these things and then come back.
And nutraceuticals today are used in different other conditions also, so that
Yes, and
acceptance
they are
also is.
mythicals. They also understand.
Yeah.
Nowadays, people
Yeah.
are very smart. They go on the they find out if there are hormones or is anything is else.
As doctors, our
And if the
greatest
mythicals,
competitor.
they don't mind to take for a long term also.
Absolute. No, as doctors, our greatest competitor is Google today.
Google, yes. Now AI.
And this type of product would also be useful in IVF procedures, before the IVF procedure, rather.
Yes. Basically, if you start in advance, helpful.
Correct. Correct.
Quality of the oocytes, that also gives good quality of the oocytes. IVF oocyte quality is very important. Then number of the oocytes.
Correct. Absolutely. Yeah. Wonderful, doctor. Thank you so much for this wonderful insights, especially insights on the products that you have used and your experience. Thank you so much. I thank all the participating doctors who took time from their busy schedule and commitments and attended the session. Thank you, marketing team Hetero, for conceptualizing and organizing this webinar. As you'll all agree with me, this type of program is successful only because of exceptional coordination from the field staff. Thank you, Hetero field personnel, for super coordination. Last but not the least, thank you, IT Hetero team, for your support and guidance in all technology related matter. Thank you once again. Thank you, Dr. Shah, and thanks once again. Signing off. Have a pleasant
Thank you,
evening.
Dr. Prashant,
Thank you.
Priya, and Vijay.
Thank you. Thank you.